Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to another episode of this channel. Let's start today's lecture. Today I have chosen a topic from middle ear, and this is very important, and this is related with infection of the middle ear, and in our rural areas this is one of the most common cause of hearing loss. I am referring to chronic suppurative otitis media. Chronic suppurative otitis media, it is the inflammation of the middle ear cleft. The term which is used is middle ear cleft, and from your anatomy knowledge you may be knowing that middle ear cleft, it includes eustachian tube, medial ear cavity proper, etitus, mastoid antrum, and mastoid air cell system. So this is the chronic inflammation of mucoperiosteal lining of this middle ear cleft. It is a long-standing infection and characterized by ear discharge and a permanent perforation. In poor countries, in developing countries, the incidence of suppurative otitis media is high, again because of poor socioeconomic status, poor nutrition, a lack of health education, and lack of health facilities. Both sexes are equally affected by this disease, and it is prevalent in all age groups. It is a persistent disease with severe destruction in one of its variety. It is characterized by hearing loss, ear discharge, and tympanic membrane perforation. It is divided into two types. The one is tubotympanic and the other one is eticoantral. Now, keeping in mind the middle ear cleft, in which we just came to know that eustachian tube, middle ear cavity proper, etitus, antrum, and mastoid air cells are included. So when we say tubotympanic, it means tube is indicating towards eustachian tube, and the word tympanic means tympanic cavity or middle ear cavity. So it means tubotympanic cavity will be involving the antro-inferior part of that middle ear cleft usually, while eticoantral, when we say atic, means atic is the part which is medial to the pars flaccida of the tympanic membrane, and antral is indicating towards the mastoid antrum and mastoid air cell system. So it means the eticoantral type of the disease will be involving the posterior part of the middle ear cleft. Another alternative classification is mucosal. Mucosal can be active or it can be inactive or healed type of otitis media, and squamosal is the when there is retraction pocket in the pars flaccida or in the pars tensa, and in active stage there will be cholesteatoma. This squamosal is again referring to the eticoantral type, while the mucosal is referring to the tubotympanic type, depending upon the lining epithelium in these parts. It is also divided into two parts depending upon their this complication rates. It is called safe type and unsafe type. Tubotympanic is the safe type. We will come to know why it is safe, and eticoantral is unsafe. Why that is unsafe, we will come to know that later on. Now, this is the nutshell of this chronic suppurative otitis media, and if we understand this particular slide, our whole topic is covered. That these two types, tubotympanic and eticoantral, this is the comparison. Of course, in both diseases there will be ear discharge, but in case of tubotympanic, the characteristics of the discharge will be that it will be profuse, mucoid, it will be odorless, and this will be copious in amount. In contrast, the discharge in eticoantral type, that will be purulent and foul smelling, and it will be scanty in amount. It may be sometimes blood stained discharge. The perforation, it is present in both cases, but in case of tubotympanic, it will be a central perforation, while in case of eticoantral type, it will be either atic perforation or it will be a marginal perforation. And to diagnose these two different types, one of course is safe, another one is unsafe, we must know what do we mean by central perforation and what do we understand by the word marginal perforation. And in coming slides I will describe it in detail. Granulations are uncommon in case of tubotympanic, while these are very common in etiquantral type, and on removal it may bleed. Again, there can be oral polyp in case of tubotympanic, but it is pale while it is red and fleshy in etiquantral. Cholesteatoma is absent in tubotympanic while cholesteatoma is present in etiquantral type. Complications are rare in case of tubotympanic because there is no cholesteatoma, because there is no underlying osteitis or necrosis. So that's why it is called safe disease. While in case of etiquantral type, the complications are very common. Hearing loss, if it is there in tubotympanic, it will be mild to moderate conductive type of hearing loss. While in case of etiquantral type, it will be conductive type, or it can be even mixed hearing loss when labyrinth is involved. In active disease, the perforation of the pars tensa in tubotympanic, and there will be inflammation of the mucosa of the middle ear visible through that perforation with mucopurulent discharge. And inactive, there will be permanent perforation of the pars tensa, but middle ear mucosa is not inflamed, and of course there will be no discharge in inactive phase. In active etiquantral, there will be presence of the cholesteatoma in posterior region of the pars tensa or in pars flaccida, and while in inactive phase, there will be retraction pockets in pars tensa or pars flaccida. Depending upon the activity of the disease, the tubotympanic type of the disease, it can be divided into acute stage, inactive stage, quiescent stage, healed stage. And as the name indicates, acute stage or active stage, ear will be discharging with that characteristics of discharge that will be profuse, odorless, copious in amount, mucoid or mucopurulent. Middle ear mucosa, which would be visible through the perforation, that will be hypertrophied and congested, and discharge is non-foul smelling. In inactive stage, perforation of the eardrum is there, but that is dry perforation, means there will be no discharge, and this perforation will be central perforation, so it will be involving only the pars tensa, and annulus will be intact and middle ear mucosa will be normal. Quiescent stage, as the name is indicating, still the perforation of the eardrum will be there, but middle ear is dry because the disease is quiet at this particular stage, and middle ear mucosa may be normal or still hypertrophied because the discharge would have stopped just a few days back. Healed stage, as the name indicates, there may be healing of the tympanic membrane by a thin scar, and there may be a tympanosclerotic patches may be seen over the tympanic membrane, and ossicular chain invariably is intact in this tubotympanic type of the disease. So this is the nutshell of all this which we just discussed. Depending upon their stages, active or acute stage, discharge will be present. In quiescent, recent past, the discharge will be there, but at the time of presentation, there will be no discharge. Inactive, the discharge or the no discharge, or in other words, ear should be dry from last 3 months at least. And healed stages, when tympanic membrane perforation has healed and there is permanently controlled middle ear infection. So tubotympanic, as the name indicates, it involves the anteroinferior part of the middle ear cleft. It is associated with central perforation. There is no risk of serious complications as no underlying osteitis or osteomyelitis, and it is usually starting in childhood. So safe type is common in that age group. The infection comes to middle ear cleft via the tympanic membrane perforation. This perforation may be a sequelae of acute suppurative otitis media, that the patient had a acute attack of suppurative otitis media are repeated attacks of acute otitis media which has been controlled, and this led to a permanent ear perforation, and from the external auditory canal the infection can go into the middle ear through this perforation. Or there is a perforation which is post-traumatic. That post-traumatic, it may be that the patient is exposed to a loud noise, or he is being slapped due to assault, there may be perforation, or due to the skull bone fractures, especially the temporal bone fractures during road traffic accidents, etc. So any kind of trauma, or even grommet insertion in children for the treatment of otitis media with the fusion, and after extrusion there is residual perforation, so that is a surgical trauma. So any trauma which led to a permanent perforation can be a source of infection leading to chronic suppurative otitis media. Following exanthematous fevers in which there are eruptions over the skin like measles, like chickenpox, so that led to acute otitis media, and then acute otitis media, it is resolved, but it left behind a central perforation which became permanent later on, and repeated infections from the external auditory canal. And if there is a perforation, middle ear mucosa may become sensitized to aeroallergens like dust or pollen from outside, causing persistent otorrhea. Then second route, which is more common, that is ascending infections via the Eustachian tube. And tubotympanic type, usually it is having a source of infection in the midline. When we say midline, it means either in the nose, nasopharynx, or oropharynx. And that's why it is more common in pediatric age groups, because in that age group, usually the children, they are having repeated attacks of upper respiratory tract infections, including tonsillitis, adenotonsillitis, or there can be sinusitis or regurgitation of the milk, etc. So that can lead to repeated infection via the Eustachian tube. And in children, we know that Eustachian tube is more horizontal, it is more wider, and isthmus is not that much well developed. Then patient can be allergic to ingestants as well, like milk, eggs, fish, which can lead to repeated infections. There is a mixed flora which is involved in that, including aerobic bacteria and anaerobes as well, Pseudomonas, Proteus, E. coli, Staph aureus, and anaerobes includes bacteroids and anaerobic streptococci. Then why we call the tubotympanic type as a safe disease? Because there is no underlying bone erosion. There is no osteitis, or there is no necrosis of the bones. It is not known to cause usually the intracranial complications. Discharge from the middle ear, it flows freely. So when there is no retention of the secretions, less chances of complications. And usually the perforation of the pars tensa, it is a central perforation which is surrounded by an intact drum. And the annulus is intact in all these cases. So perforation of the pars tensa, middle ear mucosa will be edematous and velvety. If polyp is present, that will be pale in color. Ossicular chain usually intact, mobile, but in some cases it may show necrosis. Tympanosclerosis in healed phase of tubotympanic, and fibrosis and adhesions also in healed phase. Bacteriology, as we saw, just it is a mixed flora, including aerobics and anaerobics. And this is the polyp, which is pale colored, not fleshy as it is present in the etiquentral type. This is the perforation in the tympanic membrane through which the middle ear mucosa and all these structures, they are visible. So ear discharge, we just learned the characteristics of the ear discharge, which is odorless, it is mucoid or mucopurulent, copious in amount, conductive type of hearing loss, which will be mild to moderate. Perforation is always central. Middle ear mucosa, if perforation is large, will look like pale pink, or it may be moist. And examination under microscope is must, along with audiogram, culture sensitivity of the ear discharge, X-ray mastoids, and CT scan of the temporal bone. Now, this is a very, very important slide, and we will try to describe it in detail. Now, first thing is that any disease or any perforation in the pars flaccida, that means that is an etiquentral type of disease. Because pars flaccida, medial to that is the etic region. So, whatever the perforations we will talk about with reference to tubotympanic type of disease, those will be restricted to the pars tensa only. Now, in pars tensa, when we say in tubotympanic type, the disease, the perforation is always central. Don't be distracted by the word central, because here by the word central does not mean exactly in the middle, in the center of the tympanic membrane. No, rather central here means that in any quadrant of the pars tensa the perforation can be, but if it is surrounded all around by the remnants of the tympanic membrane or the annulus, still it is a central. Its size may vary, as you can see in this first picture, in this second picture, in this third picture, and in this fourth picture. Here it is very small perforation. It is, you can say, a medium sized perforation. It is a subtotal perforation, and it is almost whole of the pars tensa has gone, but still the fibrous, this membranous annulus is intact. So any perforation in the pars tensa which is surrounded by all around by the tympanic membrane or the annulus, that is a central perforation. So it can be small, it can be medium, it can be subtotal. When we say subtotal, it means all around still the remnant of the tympanic membrane. Even it may be a small rim, it is intact. While when we say a total perforation, it means the fibrous annulus has gone, but still the bony annulus is intact. We know that the periphery of the pars tensa, that is thickened or convex, which we call as tympanic annulus or fibrous annulus, and it is attached in the bony annulus which is concave. So it is sandwiched like this. So even if that fibrous annulus has gone by the disease, still it will be a central perforation if bony annulus is intact. In contrast, these two pictures, these are related with the etiquentral. As I told you, any perforation in the pars flaccida or even a retraction pocket, which is an indication of inactive etiquentral type. So any disease or any pathology found in the pars flaccida, the disease is etiquentral type. While in case of pars tensa, if even it may be a small perforation, but it has eroded the bony annulus, as you can see in this picture, that this is the bony annulus and it has been eroded by the disease process. So this is what we call as marginal perforation, because the perforation on this side, it is not surrounded by the tympanic membrane or by the bony annulus. So this is called marginal perforation. In contrast, in this picture, the whole of the pars flaccida, this pars tensa, it has gone, but still it is surrounded by the intact bony annulus all around. So that's why we call it as a total central perforation. So that's why examination under microscope is must. In ear examination is never complete until and unless we have examined it under microscope. Now small perforation, as you can see in this picture, that by two imaginary lines, one vertical line through the handle of malleus and another horizontal line through that umbo. We divide this pars tensa into anterosuperior, anteroinferior, posterior and posterior quadrant. And in this picture you can see this is a small central perforation because all around tympanic and membrane is intact and it is confined to one quadrant. So if the perforation involves only one quadrant or it is less than 10% of pars tensa, we call it as a central perforation. Here you can see this perforation, it is involving two quadrants, inferior and superior quadrant. So it involves two quadrants, and if it involves more than 10% but less than 40% of pars tensa, we call it as a medium sized central perforation. Large perforation, if it involves 3 or 4 quadrants but with the tympanic membrane remnants all around. Subtotal perforation in the pars tensa, which involves not only all the 4 quadrants but it is surrounded still by the annulus tympanicus. That annulus tympanicus, it is intact, which I told you that it is a ring all around the pars tensa which is thickened or convexed to form a fibrocartilaginous ring. That should be intact, and then we call it as subtotal perforation. But if this tympanic annulus or fibrocartilaginous ring is absent but still bony annulus is intact, then we will call it as total perforation. But if bony annulus is not intact, then that will be a marginal perforation, and marginal perforation is the hallmark of etiquentral type of the disease. So we will continue with the investigations and treatment of this disease in next episode, and I hope the concept of central perforation and posterior marginal perforation and etic perforation is now clear, because until and unless this concept is cleared, we could not understand the pathophysiology of these two very important middle ear diseases. Thanks for watching.